Very good afternoon to all of you. At the outset, my sincere thanks to Srinivas and the whole team of IASSACON 2023 for organizing such a wonderful conference to invite me here. They're just taking a little time to connect the laptop. Now the talk given to me is DISE Beyond Classifications. Now this is a very, very deep topic because all the classifications are made to make you understand things a little easily. What is happening? So classifications are made to make you understand things much easier way, in a more way that you can understand it easily, and I am going to make it more difficult for you to understand because I am going to talk beyond the classifications. But they say that you can give somebody a fish to feed him, or you can teach him fishing to feed him for life. So in the next 15 minutes after my laptop is connected, so my job will be to make you understand what happens inside the airway. No, it's still not there.
It's a difficult airway situation.
It's a difficult airway, absolutely. System setting. Mirror displays. Mirror arrange. Hi.
It's come.
It's come here. Okay. But I cannot see anything over here.
Oh.
Okay. Arrange. Put it mirror display, no? Mirror display. Mirror. Correct.
Now it's going from here.
Better to keep
What's going from there?
they are locked. Second.
Yeah.
No. Okay. Is it here now? Okay, great. Thanks. So that's what. The picture on the left teaches you how to put your things into a particular classification. The picture on the right actually makes you think what you are looking at. So I'll try to make you understand that when you are looking inside the airway, you don't think about the knowledge which is already given to you, that okay, this will be what classification, this will be AP, lateral, circular, and you think in that way. I'll just try to make you understand what structure you're looking at and the way it works. So why we are doing this? We are looking, obviously the nasal region you can do a CT scan and understand, but you want to make out whether the problem is at the palate region or the tongue region or the epiglottis, which I think Sandeep very nicely showed you. The most important area to understand is the palate, because 95% of the patients with sleep apnea have a palatal collapse also. Right? Very rarely you will find a patient without a palatal collapse. So let's understand what are the structures in the palate. We all have been looking into the oral cavity, left, right and center. Every day you look into at least 40-50 oral cavities. But when we look at the airway, it's the same place, but we have to imagine the airway at the back, because the airway, what we are looking at is the foodway and not the airway. And the airway is this. When you look at the soft palate from the back, when the person is snoring, let us try to understand what is happening. Okay, so I'll just replay this video behind. If I take it back, now let's see what is happening. This is the motion which gives rise to snoring and sleep apnea. And let me check out. This is the tip of the uvula. This is the lower pole of the tonsil. So typically we understand that the uvula is going to touch at the back. It's not the tip which is touching at the back. It's the base of the uvula which is touching at the back. First concept. You do any surgery removing half the uvula, will it eliminate snoring? No. Either you touch the uvula or you do not touch it. If you touch it, you remove it completely, then only your snoring will go away. It is a very, very simple thing to understand. Now, this is the lower pole of the tonsil, and what is this structure going and touching at the back? Is it the lower pole of the tonsil going and touching at the back? It's the upper pole of the tonsil going and touching at the back, and it's covered by which muscle? What comes behind the tonsil? Posterior pillar. Simple anatomy. Palatopharyngeus. The palatopharyngeus has got two parts, the vertical and the oblique. Which part is going and touching at the back? Oblique part of the palatopharyngeus. Very simple. Upper pole of the tonsil covered with palatopharyngeus. The oblique part of the palatopharyngeus, this is going and touching at the back. See, in last 35 years, unfortunately, we never described the movement which is causing obstructive sleep apnea, and we tried to do this by creating some animations. So when you look at the tonsils and the structures from front, they are moving medially and superiorly, but when you look them from the side, they're also going posteriorly. What I just showed you, I have tried to explain by animation. So if this is happening, and when does it lead to sleep apnea? I'm just showing you a different angle of the same. Now when this goes and touches upper pole of the tonsil in the base of the uvula, when this goes and touches the posterior pharyngeal wall, that is your snoring and sleep apnea. So if we understand how tonsils work, how muscles work, then possibly our job will become much easier. There are 5 muscles in the soft palate: levator palati, tensor palati from top, palatoglossus, anterior palatopharyngeus from the bottom, and then musculus tubuli in between. So if I try to show you the action of tensor palati, is it coming in the airway? No, it is not. It is a good muscle. It is actually expanding the soft palate. It's not coming in a way. So forget about tensor palati. It is never required for sleep apnea surgery. Most important muscle is levator palati, because if this does not work, my voice will become like this. A, B, C, D, E, F. My voice will become like this. When I drink water, it will come in my nose. That is, these are the 2 complications that every surgeon is scared of. So now let's see, what was the area I just showed which causes sleep apnea? It was this. The levator palati is here. So this is our area of concern, and this is not our area of concern. If we understand that simple fact, our lives will become much easier. And obviously the anterior pillar is again pulling the soft palate forward. It's a good muscle. It has nothing to do. Anterior pillar, we have nothing to do. It's only the posterior pillar which is the culprit, which is blocking the airway, collapsing and blocking. Srinivas showed you a very nice surgery in the morning on working on which muscle? Posterior pillar, the palatopharyngeus. So all surgeries on sleep apnea are based on palatopharyngeus for this reason. So if you limit yourselves below the levator palati and the tensor palati, obviously you are not going to get velopharyngeal insufficiency, right? Now coming to tonsils, we all understand tonsils very well. We all are ENT surgeons, but let me ask you, tonsil grade 1, 2, 3, 4. Tonsil is a 3D structure. We only base the tonsil grade 1, 2, 3, 4 based on its tummy, only one axis. But it also has got other axis, which is the shoulder and the height. Tonsil is a 3D structure, so it has got 3 axes. So we have to think of tonsil in the 3D, not in single dimension that we are typically taught about. So if somebody has a large tonsil, T4, T3, it will be blocking the airway only in the center like this, not at the back, right? So how many patients will see tonsils like this? Very, very few. How many DISE you see like this? Almost never. Very, very rare. So when the tonsils grow, they also grow posteriorly. And that is the area where they go and block and cause more sleep apnea. So when you remove the tonsil, it will also help you in that way. Most of the tonsils are actually endophytic. So endophytic tonsils, they actually go and block here at the upper pole. And that you see in the DISE like this. See, this is not a huge tonsil, but see the upper pole covered with the palatopharyngeus. This is how the tonsils create a problem. So tonsillectomy is an integral part of sleep apnea surgery, but you have to do something to the palatopharyngeus muscle also at the same time, whether you cut, whether you don't cut. I am pro-cutting. Srinivas is, not pro-cutting. That's a different way of looking at it. but you have to do something to the palatopharynges, because the moment you remove the tonsils, your anterior pillar will pull the posterior pillar forward and will create that much more extra space at the back. Very easy. So your central is taken care of, but even the AP diameter is taken care of. So rather than going into a classification system, VOTE, very simple, we actually developed a reporting system. So this thought came to my mind, I think 2018-19. Then I talked to Srinivas and Vijay, and then this is how that VSV DISE reporting system. So just like you cannot, explain a whole patient just by saying that, okay, it's velum 1, oropharynx 2, tonsil 2, and epiglottis 1. You cannot give the entire picture. So we came up with a system which I think Vijay is going to discuss about, where we talk in detail about the nose, all parts of the nose, deviated septum, turbinate hypertrophy, nasopharynx. We talk of velopharynx. Here, first time we have talked about upper velopharynx and lower velopharynx. This is again a very, very important concept. As I said earlier, upper velopharynx is the most important area where your levator palata is functioning, and your lower velopharynx is the area that we typically that causes sleep apnea. So most of the patients fortunately have only a lower velum collapse, and we call them funnel kind of patients. It looks like a funnel. This is a funnel. You saw that it's only collapsing at the lower end. But say 5 to 10% patients are tunnel kind of patients. They collapse both in the upper and the lower part. There the problem is that you cannot cut into the levator palata and the tensor palati. There you might have to look for either CPAP or some kind of advanced palatal advancement or MMS kind of a thing. So if you have such a patient, this is both up and low. So now this will not do greatly with any kind of simple palatal procedure. So 5 to 10% patients you have to understand. Then you have salpingopharyngeal fold. This was, I'm proud to say that this was discovered in India. 2010 I described it, and 2012 we presented it, and in 2019 we got the grading done. So this is our paper for the grading. Now then comes the AP, can have the sound a little less. AP lateral collapse. Now this is, do you all understand? This is lateral. Can you have the sound a little less? This is lateral, and a combination of this you can call circular. Now this is a worldwide accepted classification. Now let me show you something. This was the AP classification.
Reduce it from the
This is AP. Let me play it from the beginning. Is this AP classification? Is this an AP collapse or lateral collapse? Lateral collapse. Is it now AP collapse or a circular collapse? Circular collapse. Now again, here it is lateral, here it is AP. See, if I give a picture, if I want to prove it AP, I'll give a picture of AP. If I want to prove it lateral, I'll give a picture of lateral. If I want to give a picture of circular, I'll give a picture of circular. We have to understand, this is a dynamic collapse. This is a dynamic situation. So what we give is not to a structure, we give it to a configuration. But you are not going to operate a configuration, you are going to operate a structure. So if something is going laterally, you pull it laterally, it will start collapsing anteroposteriorly. Has happened in my hands. I have got a lot of failures by this classification. So you have to understand what structure ultimately you are dealing with. So now if it is an AP collapse, what structure are you looking at? So this is the back of the uvula, and besides the uvula, what structure do you get? It is again the palatopharyngeus, the medial fibers of the palatopharyngeus. So you have to know the structure that you are looking at, because you are going to operate on the structure and not the configuration. So if you are only supposed to say something, write something, diagnose and give CPAP, you do whatever you want. But if you really want to give the patient a surgical cure, then you have to know what you are actually operating upon. That's my humble submission. Then see oropharynx. We again divided into anterior and posterior part. Now, this is the posterior part of the oropharynx. What surgery can you do for this part? We see a lot of patients that collapse. No surgery is as of now possible for that part. Then you have base of tongue. upper base tongue, lower base tongue, entire base tongue. This classification is not existent. But you have to know how much do I operate. Upper is foramen cecum to tip of epiglottis, lower is from tip of epiglottis to vallecula. Then you have to know whether it is lymphoid or muscular. Lymphoid, you can do lingual tonsillectomy and send the patient home by the evening. Muscles you get inside and you are inviting a lingual artery bleed. In many of the conferences I have shown my own bleeds. So you have to understand what exactly you are looking at, because you are going to operate on that structure. You are not going to operate on statistics. You are going to operate on a patient. You are not going to operate on a video or a CT scan or a MRI. You are going to operate on a live person whom you can kill. So you have to know exactly what you are looking at. Now this is a high tongue base collapse, my own failure after doing a UPPP. My own failure. Lower tongue base collapse. A totally different issue. High tongue base, how much will I remove? Low, I can definitely get a very good result. Muscular base tongue, completely muscular. I have to go at least 1 centimeter, 1.5 centimeter inside to get some result. And then I am looking at the lingual artery. Whereas huge base tongue, but only lymphoid. Lymphoid, I'll get only small feeders. I'll never get a lingual artery or a profunda lingual. I'll never get an artery, big artery. I'll only get small. So lymphoid, bad case, 96 AHI, but fine, this is a simple surgery to do. Rather than this surgery is totally different surgery. I'd rather do a MMA on this patient rather than a base tongue surgery. Whereas this patient will never do well with any MMA or anything. And this is simple base tongue surgery that is required. So obviously larynx, primary and epiglottis, secondary we all have already seen. This is secondary collapse. This epiglottis is falling secondary to the tongue. The earlier was falling only because of its own collapse. So the treatment is totally different. Then, well before all this was documented, we did all the interventions in 2012-11. We used to do all these interventions of putting scope through the airway, and then simulating a palatal surgery, simulating a nose surgery, and see what will happen to the base tongue after that. So what I'm saying is, by classifications, you can definitely write a paper, but you cannot operate a patient. If you have to operate a patient and get him out of a sleep apnea and snoring, then you have to know what exactly you are operating, which structure you are operating. You have to know what will be the result, and then you can obviously do these maneuvers to understand what is the outcome of your result going to be. Thank you very much.